Great. So thank you, guys. We're going to start the panel discussion now. I'm going to turn it over to Kim Block, who is a reporter for, or a news anchor for Channel 13, and she has in the past hosted an event for us that was part of our interprofessional education symposium that featured chronic pain as a challenging disease, and she did a fabulous job with that, and I asked her to come back and moderate this panel, and I'll let Kim take it over. Thank you.
Thank you. Hi, everyone. Thanks for coming. I'm delighted that the University of New England is once again trying to educate people on this very complex issue of chronic pain. I am here as a health reporter, medical reporter, and anchor for CBS 13, but also as a chronic pain patient. I was diagnosed about 18 years ago with fibromyalgia, which some of you may be familiar with, some may not. I would say the majority of people are not. And it's been a bit of a challenging journey. I would call myself a fairly good, if I may pat myself on the back, good chronic pain patient, in that I have taken as much ownership as I can of my health care, and that I have also decided that I will live with some level of pain. And I think you'll find most pain patients say that there's really no way to survive unless you accept that you will not have a life that is pain-free, but you must find ways to manage as best you can. So it's great that we're all looking at this issue. Certainly there's a big challenge of opioid abuse in the country, and that's certainly relevant in this context. But I think what's even more important is that we don't throw the baby out with the bathwater, and that we remember that chronic pain itself deserves recognition, treatments, therapies, strategies, attention, and education. So I'm delighted we're all here today to kind of further that effort. We have a very distinguished panel. I'm going to start by introducing our first speaker today. This is Congresswoman Chellie Pingree. I'm sure many of you are familiar with Congresswoman Pingree. I didn't realize she wasn't a Mainer. You know, she was born in Minneapolis, but that's okay. We will forgive her. She did work, though, in advertising. Her father, Harry, worked in advertising. Her mom, Dorothy, was a nurse. She moved to Maine as a teenager, so there you go, and attended the University of Southern Maine, graduated from the College of the Atlantic in Bar Harbor, elected to the Maine State Senate in 1992, representing Knox County, and in 1996, she was chosen by her peers to be the Maine Senate Majority Leader. As you know, in 2008, Congresswoman Pingree was elected to Congress from Maine's 1st Congressional District, the first woman elected to Congress from that district, and the first time in American history that women make up the majority of a state's congressional delegation. Thank you so much for being here, and come on up to the podium.
Well, thank you so much for having me here on this panel. Thank you to our wonderful moderator, who always such a great job, and thank you for sharing a little bit of your own personal story. That was very nice to hear, and good that you have this kind of connection to the complicated topic today. And I'm grateful to be here at the University of New England. Thank you to Dr. Bilski for organizing this event, and once again putting UNE in the position of bringing together all different kinds of people to talk about a very challenging topic. I think all of us who live in the state of Maine, and particularly those of us who get to represent the state, and given the fact that Biddeford is in my district, I am very proud that we have this wonderful institution here, and I'm always impressed with the creativity and constant growth and the wonderful people who are engaged in this institution, and I know it's going to continue to grow and continue to be a source of great pride in the state of Maine. Every once in a while, people will say to me, "We don't have a medical school in Maine," and I'll say, "Seriously? We have a medical school, and we're very proud of it." Well, I'll just jump right into the topic, and look forward to hearing from the rest of the panel. I think most of you in the room probably already know that this is one of 61 medical schools in the country to commit to providing education to help prepare future doctors to carefully balance those risks and benefits of prescribing opioids. I think it says so much about the university's commitment to this issue that the new class of medical students are receiving such a comprehensive introduction to the issue so early in their education, and I'm very glad to be here to encourage even more of that. As I said, I'm going to try to be brief here just so we can have plenty of time to hear from our two incredible experts who we're very happy to have join us on the panel today. I don't have to tell you that, like the majority of Congress, I'm actually not a doctor or a scientist. And I think those are clearly the most important voices in these conversations, are those of the patients and the medical professionals. But because I'm an elected official, I think I have somewhat of a perspective on these sorts of complex issues, because I have an opportunity to hear from a very wide range of people impacted by policy changes. In our office, we hear from the families of people who have lost their lives to substance use disorder, to healthcare providers who are deeply concerned about the over-reliance on pharmaceuticals, as well as those individuals who benefit from them. One pain patient in particular, her story has stuck with me, and I want to describe it. She suffers from chronic debilitating migraines and relies on opioid medication to maintain even a bearable quality of life. When I listened to her story and those of other pain patients, it became very clear to me that a lot of the rhetoric being used by my colleagues in Washington wasn't necessarily reflecting the experiences of people with chronic pain. Although great progress has been made in diagnosing and treating pain by professionals at the Department of Health and Human Services, it's taken the tragic increase in opioid abuse to bring national attention to this issue. And there's one thing that we know is there's a lot of national and state attention to this particular issue. Unfortunately, I think some of that attention has created a great deal of misunderstanding about the legitimate and necessary use of opioids by some pain patients, and it's fostered a lot of stigma about chronic pain sufferers. It's not to say that I don't recognize a serious problem in the over-reliance on these drugs, especially for acute pain. Clearly, when we have as many active prescriptions as we have adults in this country, something has gone wrong. It's undeniable that there is a connection between misuse and diversion of such powerful medicines and continuing substance use disorders. Some of the steps that Congress has taken, like moving toward providing more funding for prescription drug monitoring programs and allowing patients to only partially fill their prescriptions when they choose to, are solid steps to ensure that these medications don't end up in the wrong hands. But all too often, the policymaking process can be fairly compared to a pendulum, swinging back and forth between extremes as lawmakers seek to address the concerns of their constituents. That kind of reactionary response is something I think we all need to be very skeptical of, especially in the context of an issue that impacts people's lives so directly, to have that in policymakers' hands. The opioid epidemic crisis is a crisis. We all know that. It should have a strong federal response. As we've seen in Maine, though, limiting access to prescription opioids doesn't solve the entire problem of addiction. As diverted medications have become harder to find, heroin and other drugs have clearly taken their place. So unless we address the underlying substance use disorder and provide the kind of wraparound supports that people need to get back on their feet, it's just all too easy to find other illicit forms of opioids. This is one area where I think there are great opportunities for both substance misuse and pain treatment to work together, advocating for greater access to mental and behavioral health services. In conversations with individuals with chronic pain, something that has come up repeatedly is the mental and emotional toll that pain takes on patients and families. One local pain support group here in Maine suggested to my staff that perhaps regular check-ins with a behavioral health professional could be required in order to allow them to access their prescription opioids with as little inconvenience as possible. I generally think that's a good idea, one which would help to prevent drug diversion while also providing much-needed support to people suffering with chronic pain. Unfortunately, it would also be challenging to implement because the current ways we pay healthcare professionals don't necessarily encourage them to work collaboratively or to take proactive steps to ensure the well-being of their patients. Instead, unfortunately, I think we all too often put providers in a position where they have to wait for something to go wrong in order to be compensated for seeing their patients. Clearly, that's not a good system. Even then, under many systems, there's a lot of pressure for them to see a patient, diagnose them, and get them out the door with a solution of some kind as quickly as possible. Along with more targeted solutions, I believe that creating an environment where our healthcare providers can focus on the individual and unique needs of their patients would go a long way towards both improving treatment for chronic pain and reducing the reliance on and misuse of opiates. In addition to spending more time with patients, I'd like to see primary care providers have more options for the treatments that they can offer. I have long been a believer in integrative medicine, and I'm pleased to see researchers recognizing that complementary treatments like acupuncture and chiropractic manipulation are effective in improving quality of life for many pain patients. But sadly, until we change federal policies, often options like those are difficult or impossible to access unless you can afford private insurance. I firmly believe that the quality of care shouldn't be determined by ability to pay, and that our country could save money by providing more personalized treatment for beneficiaries of Medicare and Medicaid. And I spent a lot of my time in Congress advocating for those programs to be more inclusive of a wide range of health practitioners. So I've talked a little bit about the big picture here, and like you, I think I'm anxious to learn more of the in-depth work that Drs. Porter and Carr are going to explain to this. But I hope giving you a little bit of the perspective from a policy side and a political side gives you a sense of the context in which their recommendations have to be enacted. I'll look forward to exchanging more ideas in our question and answer session. Thank you very much.
Thank you so much, Congresswoman Pingree. Our next speaker has certainly been on the front lines of trying to not only explain chronic pain and all of the affected issues, but also strategizing how best to deal with the issue. And I don't think you can fully do that unless everybody understands what we're dealing with, and so her work has really been critical in that regard. Dr. Linda Porter joined the National Institute for Neurological Disorders and Stroke in 2003. Dr. Porter holds a Bachelor of Science in Physical Therapy from McGill University, a Ph.D. in Neuroscience from Boston University School of Medicine. She trained in neurophysiology at the Rockefeller University and was on the faculty of the Uniformed Services University of the Health Science for 15 years, where she directed an NIH-funded research program aimed at elucidating mechanisms of sensory-motor integration. She became the director of the newly established Office of Pain Policy in 2012, for which she supports the activities of the NIH Pain Consortium and the activities of the Interagency Pain Research Coordinating Committee, and she co-chaired the development of what I was referring to, the National Pain Strategy, and the ongoing development of the Federal Pain Research Strategy. So please welcome Dr. Linda Porter.
Thank you so much for the introduction, and a big thank you to Ed and Danny for all their hard work in making this a really interactive and exciting meeting. I'd also like to begin by saying a thank you to Congresswoman Pingree for really setting the stage of why we need a change in how we manage healthcare as a nation. And so I'm going to talk to you today about how the National Pain Strategy was born, a little bit of the background that led to it, and some of the steps that we've already taken to begin to address the objectives of the National Pain Strategy. And this is an effort that really included an enormous team of people. The National Pain Strategy included about 80 different experts, all volunteers from across the federal government, from outside professional organizations, from people with pain, for advocates for people with pain, a really broad swath of people who spent a lot of time, a lot of energy in making the National Pain Strategy happen. So in the press release, when the National Pain Strategy went out in March of this year, there was a description of the National Pain Strategy being the government's first broad-ranging effort to improve how pain is perceived, assessed, and treated. They look at it as a significant step to the ideal state of pain care. And I really hope that the steps, it's really a multiple set of steps towards that ideal state of care, will happen in the near future. We'll begin to see changes from this. I would like to say that the government's first broad-ranging effort doesn't really reflect that this is a national strategy, and it includes the government clearly as a leader in moving the the objectives forward, but also really included in its development and as we go forward in the implementation, stakeholders from across the pain community. And so that really is an incredibly important thing. And to go back to Ling's comments earlier this morning, that the stakeholders that will be involved is we can always do more. And I think that's a really, really, really nice message. So why did we need a change in how we approach healthcare? Well, we have two public health crises, significant crises. One is the prevalence of pain at the national level and the suffering at the individual level. So according to the IOM report, 100 million American adults, and this is not the entire adult population, report chronic pain, pain that lasts for more than 3 months out of the year. 25 million people report pain on a daily basis. They wake up with it, they go to sleep with it. 3.7% of the population has pain which interferes with their lifestyle. This comes to about 6 million people, and that interference can be to the point where it will preclude people from participating in social activities and doing their household chores. They may not be able to go to work. They may not be able to get themselves to school because of the difficulty with living and coping with this pain. It costs the nation somewhere up to $635 billion a year in lost productivity from chronic pain and in healthcare costs. This is a staggering number. We know, though we have very poor data to understand how global the difficulty in accessing quality care is, but we know it's limited to vulnerable populations, it's limited to people who cannot afford high quality health care, it's limited according to where people live and to the availability of care in their neighborhood and whether or not they can pay for what's needed. So the other problem that has really brought the need to improve pain care into the spotlight nationwide is the opioid abuse, overuse, and death issue. This is one of many, many statistics that you've heard about, seen about, read about in the news over the last year or so. We know that at least 2 decades ago, there was a transformation in how opioids were used to relieve pain. They became much more frequently prescribed. And over the course of 20 years, you can see that the rise in rate of sales of opioids, of opioid-related deaths, and of treatment admissions, primarily to emergency rooms, rose in parallel to the point that the death rate now, I think the latest statistics on this, this has obviously been updated, is approaching over 40,000 deaths per year related to opioids. This is an enormous problem in the epidemic range. So we've come to the point where several really high priority initiatives have been started through the federal government. And many of those, although they are more focused on the opioid issue side, are being recognized as needing the balance for appropriate pain care. So even though in the news you hear much more about the opioid issue, I think at the federal level, all the way up through all the tiers of Health and Human Services, the dialogue and the messaging is that we really need to approach this from both sides. So very briefly, some of the initiatives that have come out somewhat recently is the Secretary's initiative on overdoses and deaths due to opioids. And this is kind of a three-prong approach for better educating prescribers, for medicated assistant treatment, and for the expanded use and distribution of naloxone for overdoses. The guideline for prescribing opioids that came out from the CDC in March of 2016 has a number of different guidelines. I think that Dan Carr will talk a little bit more about this. But in their preamble, they recognize that improving the way opioids are prescribed can ensure access to safer, more effective chronic pain treatment, while it reduces the reliance on opioids. This balance is so important, and we've heard about it over and over throughout the course of today's presentations. The FDA has released an action plan on opioids to provide a closer scrutiny of how they do labeling for new drugs, for post-market studies of the safety of new long-term opioids. They're bringing in more expert advisory panels to make decisions on how they take these steps forwards. They're pushing for better education and evaluation of education strategies for prescribers. So a lot of activity at the FDA. And then here, not meant to be at the bottom of the list, is the National Pain Strategy. And the preamble within the National Pain Strategy, again, you see the balance of the need to work these two issues together. That we need a healthcare system which will provide comprehensive pain management through which integrated care would provide alternatives to opioids. This pain strategy does not call for stopping opioids. It calls for better alternative to opioids and recognizes that opioids may be an important part of a good pain management strategy. So how did the National Pain Strategy come about? Well, in the Patient Protection and Affordable Care Act, there were a number of provisions on pain care and pain research. And one of those called for an IOM report, Relieving Pain in America. This has been actually a really well accepted, nicely written document that overviews the challenges that we face in better pain care, looks at the gaps in our evidence base for pain management, needs for better pain assessment. It's proven to be an incredibly important document. So the other thing that the Patient Protection Affordable Care Act called for was the establishment of an interagency pain research coordinating committee. And that committee membership was established to include federal partners, scientific partners, including both clinicians and researchers, and members of the public, patient advocates and people with pain. And that committee's mandate was primarily related to pain research across the federal government, to better coordinate it, to make sure that there's no overlap, to make sure there's some kind of a long-term strategic plan. Well, that committee, with all of its research experts, was visited by Howard Koh, the Assistant Secretary for Health at the time, in 2012, who asked the committee and the NIH to take on the development of a plan, a nationwide plan, which would address the recommendations put out in the IOM report on pain. In that plan, he wanted us to assess research, care, perception of pain, all at the national level. And he wanted in that report to have discrete objectives which had steps that were achievable and over a short period of time. So the Interagency Coordinating Committee was a little bit hesitant to take on this rather daunting task initially. And I'm going to point the finger at Sean and say he was one of the most hesitant and outspoken members, saying that this was beyond the scope of the committee. And within the course of about an hour, Sean was the lead on this project and did an amazing effort, put his heart and soul into it. He's still behind it, and he still asks me probably on a bi-weekly basis, what more can I do to help? And so it's turned out to be a very comprehensive document, and along with Sean, so many other people helped us. Dan Carr was a big player in this as well. So we have a pain strategy that is aligned with the recommendations of the IOM report. We broke it into 6 subgroups or working groups, if you will, with these 80 experts spread across, some of them serving on more of one of these work groups. And over the course of a year, these work groups came together and put together a set of recommendations that were discrete, achievable steps over the course of 5 years. The hope was that the accomplishment of those steps would change how we approach pain care. So one of the groups is population research, chaired by Michael von Korff, and Dr. Scher from USIS, disparities, co-chaired by Nadine Gracia, who is the Assistant Secretary at the Office of Minority Health, and Carmen Green, who's done a lot of research in this area. Prevention and care, Sean Mackey, Dan Carr co-chaired this one. Services and payment, Bob Kearns, Mark Wallace. Professional education and training was Matt Gallagher and Jim Rathmel. And public education and communication, Penny Cowan and Linda Harris. So some really dedicated people. You can see that this document really does address a broad range of how we need to change the foundation of pain research and how to go about it. The thing that we are adding on, I mean, research, the need for better research is highlighted throughout the National Pain Strategy. It does not, however, include a very defined research, long-term research strategy for the federal agencies that support pain research. But we are moving forward with the effort now. It's ongoing. It's aligned with the National Pain Strategy, and it will serve as a sister document to fill out the recommendations of the IOM report. During the implementation phase, something that wasn't clearly called for in the National Pain Strategy, but clearly needed, is a means to report on the progress of the achievable goals that we have in there, and also on communicating the progress of the strategy to the outside community. So just to go very quickly through the framework and the primary objectives of each of the groups. Population research, and I think Sean pointed this out really clearly at the luncheon presentation, is that we need better data on what the prevalence of pain is and what interventions might be effective and cost beneficial at the national level. And so this group put out 3 objectives: estimate the prevalence of chronic pain and high-impact chronic pain. And I will come back in a little while to why we've defined high-impact chronic pain through the National Pain Strategy. The second 2 is to define and employ standardized electronic healthcare data methods to determine the use and cost of care. Obviously, this is becoming a big part of our healthcare system, and it needs to be used effectively for better data. And to develop a system of metrics to track changes. So trends in prevalence, impact, treatment, and cost. What are we doing right, and what are we doing wrong that we need to change? The disparities group recognized that vulnerable populations really did not get access to quality care. And this is across a broad swath of what they defined as vulnerable populations. So they called for reduction in bias and its impact on pain care. They called for the need to improve access to care. They called for better communication amongst patients and providers, and especially amongst populations who have communication disorders, language problems. They also called to enhance data on the impact of pain for high-risk populations, what access challenges they have, and what it costs the government to leave these disparities unattended. And prevention and care, there was a clear recognition. Again, they pointed out the lack of accessibility to quality care for all, and a clear recognition that we needed to do better with pain self-management programs on a national level, to look at what we've got, leverage programs that are working well for other chronic pain conditions, and put them into place for better pain prevention and better pain management. Also to develop standardized, consistent, and comprehensive pain assessments and outcome measures across the continuum of pain, i.e. from prevention, acute, into chronic pain. And services and payment, clearly pain care needs to change, but part of that is changing how the private and public insurers will reimburse providers for the care that they need, to reimburse for multidisciplinary care, including needed and appropriate complementary therapies, pharmacological and non-pharmacological therapies. And here, enhance the evidence for care. So we know we need to pay for better care. We're pretty sure multidisciplinary care is needed for many people, especially with complex pain conditions, but we really need the evidence base in order to give the best care and in order to make sure that it will be paid for as needed. And here, this is a little more specific, incentivize payments for quality care based on biopsychosocial model of pain. It needs to be integrated, it needs to be cost-effective, and it needs to be comprehensive. And professional education and training, I think it was recognized in the IOM report and the people that served on the panel that educating the providers, especially for complex pain management, complex pain conditions and management of those conditions, is something that places like UNE seem to be doing a really wonderful job in approaching that with sort of new, innovative ways to look at education and bring new approaches into their curriculum. But this doesn't happen across the board on a national level. And that improving provider knowledge is absolutely crucial to improving pain care. So they had two specific objectives: to work on core competencies, which they envisioned beginning at the pre-licensure level, moving through primary care, and then all the way up through the specialty levels. And these would include competencies for pain management, also including compassionate care and reduction of bias. Their other objective focused on developing a pain education portal. So this was envisioned as a centralized website where curriculum tools that are appropriately evaluated and updated on a regular basis could be housed, and these would be freely accessible. So we have a program at NIH that would be leveraged, which I'll give you a little bit more information on further along. And the last of the groups, public education and communication, and the need to really educate the public about what it's like to live with chronic pain, the stigma associated with chronic pain, and the impact of chronic pain on individuals who suffer. It's really misunderstood. And they also called to develop and implement an educational campaign for safer medication use, especially opioid use for patients with pain. And so I mentioned that those work groups were not inclusive of a very targeted research strategy. We are now working through the Interagency Pain Research Coordinating Committee and my office to bring all the federal agencies together that support pain research across the government, sit down, and they have been sitting for hours and hours and hours to develop research priorities that will align with the National Pain Strategy. We'll go back to the federal agencies to put them into place and really enhance the federal pain research agenda. We expect that to be done hopefully January of next year. So a couple of things have already moved forward that were recommendations for deliverables in the National Pain Strategy. So we've made some small steps with the resources that were available partly during the development of the plan and then some a little bit later on. So I don't know if you're all familiar with Healthy People 2010, 2020, but the Healthy People program that came out of HHS over a decade ago is a program to define the health objectives for the nations for chronic diseases, and really to make quality of life better, more free of preventable disease and disability of injury, improve health equity, create environments that promote good health, and promote quality of life, better, healthier behaviors, And one thing that was missing from Healthy People 2010, 2020 were objectives for chronic pain. And so some of the folks in the population research group worked really hard to meet a deadline to get developmental objectives into Healthy People 2020. And they were successful by meeting the deadline, I think, within 24 hours. It's a very complicated process. And so what they've got in 2020 is to decrease an objective that would be to decrease the prevalence of adults with high impact chronic pain. And again, I'm going to come back to this to explain a little bit what they mean by that. These other 3 objectives are on hold for Healthy People 2030, and we're actually moving into development of Healthy People 2030. So this was good news. What we needed in order to get this in was population level survey data to serve as a baseline in order for this objective to be included in Healthy People 2020. If we don't have a baseline, we don't know whether we're decreasing or not. And so we were able to get, with the help of a number of folks, again, Dan and Sean were both involved with this, in developing questions that would go into the National Health Interview Survey. This is a huge survey that goes out to tens of thousands of people every year. The questions are the same over the course of multiple years so that the data can actually be integrated over the course of a number of years. And so one of the things that we got in was trying to get at the concept of high impact chronic pain. And so just to back up a little bit, during the NPS development, high impact chronic pain was defined as having pain for 6 months or more that interfered with different parts of your life. So functional and quality of life interference. And so that we did a pilot study, the questions were evaluated, and so we were able to incorporate these 2 questions to try and get at the level of high impact chronic pain, rather than just saying 100 million people have chronic pain, but what does that mean to them? How does it affect their lives? And so hopefully these questions being in the survey will help us to get at that huge question. So I mentioned that the screening tool, in order to put those questions on the National Health Interview Survey, were developed during the pain strategy development, and that the questions have gone in. Since then, there have been a number of publications that are beginning to start to define the use of especially complementary services by people with chronic pain, how much it costs, and the benefits of those services, the public health impact of high impact chronic pain on people's abilities to maintain their quality of life. And there's now a study going on through the Assistant Secretary for Planning and Evaluation and a number of different agencies, looking at what CMS now covers for some chronic pain conditions. The pilot is starting with chronic low back pain, and also some private payers. So with that information, we can see how feasible it is to do that kind of a study on a nationwide level, and then start to move into how we need to change the payment system in order to meet the quality, multidisciplinary care requirements that we're asking for. And so a couple of other things that some of these you may know about, the NIH is funding contracts for Centers of Excellence in Pain and pain management for undergraduate training. And these will be case studies, complex pain conditions, that are posted on our website. And we have one up there now. Her name is Edna. It's a real patient. It's sort of an interactive video and set of questions for assessment, diagnosis, treatment, and management of this person. And that can be found if you just Google NIH pain. You'll get to the consortium website, and it's highlighted on our website. We were also able to get one of our principal investigators from one of these centers to help out on the CDC webinars. They've got a whole series of webinars to help with training on prescriber education. And a couple weeks ago, they did one that included a complex a complex patient management. I thought it was really, really well done and very informative. The core competencies, and this is an example where the federal piece really is not the federal government that's doing national pain strategy, but this is an effort led by Scott Fishman and his colleagues to really enhance core competencies for pain care at the pre-licensure level. There is a publication that he's come out with. A summit that they held included 30 undergraduate professions. They all endorse these core competencies, and they will serve as the baseline to move into primary care and into the subspecialties. This is a wonderful tool developed by the Office of the Assistant Secretary. It's an interactive video where you can choose to make decisions for the pharmacist, the nurse, the physician, and the patients. If it's a bad decision, the outcome is bad. If it's a good outcome will come from good judgment on the part of all these people throughout the process. So it's a really wonderful educational tool, and I would recommend having a look at it. And lastly, something that came out just recently, the Secretary asked all of the agencies a little while ago to dig into their research portfolios on opioid and pain management and summarize the things that we are currently doing, that we plan to do, related to the opioid issues and improving alternative pain therapies. And with that, there are strategic elements for research recommendations that highlight both pain management and issues related to opioids. So we were really happy that the pain management issue is up front and center in this document. And this document calls for that research to be done 2016, 2017, and then on into the future. So I think this is really important. We have a structure in place to move forward with the rest of the deliverables in the National Pain Strategy. It includes leaders of a number of different federal agencies. They've already been appointed. It includes a steering committee, which will be led by Tom Novotny from the Office of the Assistant Secretary and myself, to really pull together a sort of a coordinated plan, which they would hand off to a set of working groups, which would be federal people who are involved in developing the National Pain Strategy, along with many, many outside stakeholders who are really anxious to get in there and help out with us. And again, that will have a tracking and evaluation component to it. Make sure we're on track, make sure we keep the timeline, make sure we communicate with the public. So I will turn this over to Dan. And thank you very much for the opportunity to be here.
Thank you, Dr. Porter. Before Dan comes up here, let me give you a little bit of an introduction for him. He is the current president of the American Academy of Pain Medicine. By the way, feel free to send me a survey. Fascinating stuff. He is a professor at Tufts University School of Medicine, founding director of its interprofessional program in pain research, education, and policy. Founded in 1999, it is the only such program worldwide based in a Department of Public Health and Community Medicine. A clinician and investigator, Dr. Carr has published in pain research, evidence-based medicine, and the social and political aspects of pain relief. Key in developing multidisciplinary pain treatment centers and clinical pain fellowships at the Massachusetts General Hospital, Tufts New England Medical Center, and St. Elizabeth's Medical Center, all just down the road in Boston. He has been published extensively. We're very happy to have him here today. Please welcome Dr. Carr.
Thank you, Kim. Well, I've really enjoyed myself, and I feel very privileged to be asked to speak amidst such a distinguished group of speakers, among whom I would certainly rank highly Dr. Porter, who did a phenomenal job in the events, in the processes leading to these publications she described. As Dr. Bilski and I were talking about what would be a useful topic to speak about, the topic of the CDC guidelines came up because they have now emerged to dominate the current discussion about how do we treat patients with pain with opioids outside of the palliative and terminal care. So Quo Vadis is Latin for where are we going? And that's the topic of my talk. So as Dr. Porter did, I'm going to give you some background for about 25 or 30 minutes. My intention is to leave a lot of time for discussion afterwards. So here's what I'm going to do. I'm going to give you that background and also point out something that may not be obvious. People accept CDC guidelines, but we're talking about opioids that are medications approved by FDA that are studied by the National Institute of Drug Abuse. So why is it CDC that came out with the guidelines? And I'll give you a little bit of the history on that. I'll talk about the preparation process. There was another report that was issued a couple of years earlier by the Agency for Healthcare Research and Quality that was an evidence report on opioids for non-cancer pain. I'll refer to that because while there are strengths in these documents, and there are tremendous strengths, I think a fair and balanced description of them would also point out weaknesses and also what's next. As the current president of the American Academy of Pain Medicine, every other month I contribute a president's message to its journal called Pain Medicine. And one of the most recent ones I did was a contrast between what I thought was a very transparent and comprehensive process followed by the National Pain Strategy under Linda's and Sean's direction versus, I'd say, a more fast-tracked process followed in the CDC guidelines. So at the outset, if we're talking about background, if we really want to step back and get the big picture, I think it's always worthwhile to go to some of the sages of the ages. Maimonides was a middle-aged scholar who became a physician to support his family after his brother died, and the brother was the chief source of income. He has a lot worth it listening to. And he said, if anyone declares to you that he has actual proof from his own experience of something that he requires for the confirmation of his theory, even though he be considered a man of great authority, truthfulness, earnest words, and morality, yet just because he's anxious for you to believe his theory, you should hesitate. So I'd like you to keep that in mind. Let's keep in mind another big picture thing. Pain is distinctive. It's a very distinctive symptom among all of medicine. And we don't respond to patients' pain the way we do to other symptoms. So I would actually push that a little further and say that in the developed, prosperous countries, many basic needs are actually excessively met. In other words, our need for food has morphed into a need to lose weight because we've done too good of a job at meeting that need. Our clothing, we have cluttered closets, and we don't just want to clothe ourselves to avoid perishing, but we want to look a certain way and be stylish and up to date. Same thing with shelter. We don't just pile up cinder blocks to keep alive in the cold Maine winters, but we want it to look nice and have a certain look. On the other hand, consistent epidemiological evidence shows that pain is widely undertreated, often in people who are vulnerable and stigmatized, the very young, very old, people with HIV, people with cancer. So there has to be some constellation of social and cultural forces that oppose addressing or meeting this very basic need. So here's an audience poll. It's late in the day, wake you up. The leading cause of disability worldwide in adults, in the developed nations for sure, is what? Cancer, mental illness, including addiction, firearm and other violence, heart disease, low back pain. A, voters for A. B, C, D, E. Well, this is data which originated from a very objective monitoring process called the Global Burden of Disease. It has some funding from WHO, some funding from the Gates Foundation. It's a dispassionate group that has no particular skin in the game as far as opioids are concerned. They typically acquire data, validate it, clean it up, and it takes a couple of years to get into print. What they did was publish a multi-page, very information-dense article in The Lancet, and then the popular magazine, The Economist, picked it up and put their data on a map of the world. And as you can see that in the prosperous developed countries, typically on the north, low back pain is the #1 cause, but also in the prosperous areas of South America and Asia. But then if you look at the other causes of disability, depression, this is a code word for other kinds of anemias like sickle cell anemia, HIV, diabetes, war. If you think of why these other things also cause disability, very often it's because of pain. So at the outset, I certainly have no intention to minimize the tragic consequences of opioid abuse, but if you look purely at a burden of disease estimate, as you've heard from, first of all, Congresswoman Pingree, and also from Linda to some degree, the burden of chronic pain is a log order greater than the burden of addiction. We can quibble about how you do these computations, and this is not meant to minimize either of them, but it's worth keeping in mind. If you look at the history of pain treatment, many of the authors that have been very influential in pain research and treatment have commented upon the issue of addiction. So Henry Beecher was one of the pioneers in measuring pain, the pioneers in characterizing the placebo effect. He wrote in his classic 1959 book that there is nothing new in man's attempt to alter the workings of his own mind. This is as ancient as the history of the human race and doubtless antedates history. Another pioneer in the area of pain was John Bonica. He set up the group at the University of Washington in Seattle, from which we hear many experts provide opinions to this day. I did get to meet him. We had a couple of things in common. We can talk about that later. But in his single author, 1,500-page text that he produced in the late 50s, he said many patients with chronic pain have conflicts that center around obtaining medications. He said the physician who's unaware of the psychosocial dimensions of chronic pain will fail to identify the vulnerable patients, become frustrated, and wonder if the patient is a drug addict or the psychological symptoms are the cause rather than the effect of the pain. As I personally began to enter the world of pain treatment and research, one of the very influential figures was Ronald Melzack, Canadian at McGill University. He gave a presidential address to the International Association for the Study of Pain, and he generated this diagram. He had government drug control agencies dealing with street addicts, but then this other circle, a bigger circle, being patients in pain. And he said then government drug control agencies have a difficult time maintaining a balanced understanding of these two completely different kinds of people. Similarly, medical and nursing schools and healthcare practice reflect our general failure to distinguish between street addicts and people in pain. I think there are a lot of nuances we could talk about, but I think what we've seen is a huge pendulum swing between Ron Melzack's call to liberalize pain treatment and the issue of how did that create or promulgate addiction. A very important article in the recent history of how attitudes evolved was by Russell Portnoy and Kathy Foley, two palliative care physicians working out of Memorial Sloan Kettering in New York City. They acquired a small clinical series of patients that they were taking care of who did not have cancer, who were not getting palliative terminal care, but instead had chronic non-cancer pain. They published this very influential article in 1986 based on just 36 patients. And what did they get from their clinical experience? It wasn't a randomized blinded trial. It was clinical experience. They said what they think is that a single committed physician should evaluate ongoing medical and psychological problems. That person should be available. The physician should make the clinical judgment that higher doses will not be salutary or the treatment should be stopped. So they'd identified that escalation of dosing was not always a good thing. They said most patients, and they cited the literature to that date, have required modest doses. The need for high doses must be scrutinized to ensure drug is appropriately used and that pain is the symptom being treated. They had surveyed the literature. There was suggestive evidence for safety and efficacy, but the paucity of data dictates caution and use in otherwise refractory patients. Over the next 10 years, Russell Portnoy became a spokesperson for this point of view, and by 10 years later, in another follow-up article in the journal he edited, he said the available data do not support doctrinaire pronouncements about the role of opioid therapy in chronic non-cancer pain. Controlled clinical trials are needed. The lack of such trials should not exclude empiric treatment where medical judgment supports it and therapy is monitored and documented. What should be documented? Pain, side effects, functional status, drug-related behaviors must be ongoing and explicitly monitored. Worth keeping in mind. Let's fast forward to the recent history. I can't claim to give you the entire context, but I'm trying to hit the high points and leave a lot of time for discussion. A group known as Physicians for Responsible Opioid Prescribing, or PROP, filed a citizens petition with the Food and Drug Administration based upon the fact that an increasing body of medical literature suggested long-term use of opioids may be neither safe nor effective for many patients with chronic non-cancer pain, especially at high doses. So this group petitioned the FDA to change the label for opioids. And what specifically they wanted was the word moderate to be dropped from the indication of moderate to severe pain. A cap on the daily doses of 100 milligrams of morphine or morphine equivalents daily, and a cap on the duration of therapy at 90 days. This was widely circulated, and many, many players got into the act, including members of the Senate Finance Committee. And it created divisiveness in the pain community. The net result was, though, that the FDA did take this seriously. It took them the better part of a year to do this. And in their response letter, said the petition is granted in part and denied in part. The FDA agreed that there were disproportionate safety concerns with extended release or long-acting opioids and emphasized that they should be used only when alternative treatments are inadequate. They also said that all of the new drug approval applications for this group of formulation of opioids should include studies that would assess the risks of opioid use in the real world after they were put on the market. This very comprehensive document that I'd recommend to anyone who wants to follow all the steps of how this evolved, a very, very well-written document, comprehensive, confirmed that each patient's risk level for misuse should be assessed before therapy, and all patients should be monitored. A new black box warning emphasized the risks of opioids, including not just to the patient, but if the patient were a pregnant woman, this would include neonatal opioid withdrawal syndrome, and emphasized that the treatment of pain, because it's a biopsychosocial entity, should not just be based on its intensity. That response disappointed PROP, and they said that they would take another pathway. They threatened to sue the FDA, but that never materialized. But around the same time, because of personal connections with people in PROP and the FDA, I'm not an insider, I don't know what actually happened. There must have been some dialogue, though. So why CDC? You've seen some of the data on opioid use from Dr. Porter. I chose this particular map because when you look at the number of overdose deaths attributed to opioids, mapped in this way, it does look like an epidemic. There's certain population centers that got bigger and bigger and wider. So it's like an epidemic. The depth and the geographical extent both grew. So the CDC is not an illogical place, but it was historically, I'd say, unprecedented that a detailed clinical guideline would come out of the CDC. But if one watched the publications, in retrospect, looking back at them, in 2013, the CDC was already assembling comparisons of what were the shared elements in guidelines for opioid use produced by a variety of professional organizations, such as the American Pain Society, such as the American Academy of Pain Medicine. And these shared elements, I think, are very prudent and very consensus elements. In other words, a physical exam and pain history should be done, along with a past medical history and family and social history, urine drug testing when appropriate. A wide range of treatment options should be considered. Patients should be started on the lowest effective dose. There should be pain treatment agreements stipulating what's the behavior, for example, not to obtain opioids from two groups of prescribers at the same time. Documentation and monitoring of ongoing pain, progress through whatever therapies like physical therapy, and using a prescription drug monitoring program to ensure that there wasn't surreptitious obtaining of opioids from another source. Greater vigilance at high doses, and using caution when tapering and discontinuing opioids. So the CDC guideline process was a controversial process. It actually was a panel whose members were not publicly known and initially had no patients on them. So in contrast, the National Pain Strategy had many representatives who were, in some cases, themselves patients. There was one pain specialist, and I've used an inflammatory word, distorted, but I'll show you why I used that word to describe the evidence review, and very little opportunity to provide input from the pain community upon the draft document. So I've referred to this evidence review from the Agency for Healthcare Research and Quality in 2014. I'll walk you through this because I probably have to repeat this twice because it doesn't sound possible, but The same expert consultant on reviewing the literature as led in this effort had also led or been involved in 2 prior efforts. The 2 prior efforts I'll describe to you were basically guardedly positive or cautiously positive about the use of opioids in selective patients. Not very different than what you saw in the 1996 paper by Foley. So what was different, though, was that in order to include a study as evidence that would inform this document, the study duration had to be greater than 1 year. That was a small change, but a very important change, because setting that new threshold resulted in 0 studies meeting that threshold. So there were no studies actually included. Most people don't, they feel like I'm not expressing this correctly, but in fact, if you look at the publication, the primary publication and the secondary publication that came out in Annals of Internal Medicine, in fact, there were 0 studies. So, who do you believe? Well, I mentioned the same methodologists from Oregon State Health Sciences University, and the same methodology did a first report on this topic. It was a guideline on opioids for chronic non-cancer pain, published in 2009 with support of American Pain Society and American Academy of Pain Medicine. It searched the literature up until a couple of years before the publication date, got 8,000 abstracts, found 14 systematic reviews and 57 primary studies. The conclusion, and I quote, is that clinicians should consider a trial of chronic opioid therapy for chronic non-cancer pain when potential benefits are likely to outweigh risks and there is no alternative therapy likely to pose as favorable a balance of benefits to harms. There was another review with an independent search which was conducted under the auspices of a worldwide group on evidence-based medicine based at Oxford University. This is the Cochrane collaboration. Similar review, similar conclusion, co-authored by the same lead author as 2009. The 2014 evidence report and the spin-off document in the Annals of Internal Medicine on the same topic used the same people, the same literature was searched. Almost 4,000 articles were screened. For various reasons, 3,000 plus were excluded as low quality, not having data, leaving 632. But then of the 632, 595 were excluded. The most common reason for exclusion was inadequate duration, and in the 2014 document, that was defined as being up to or equal to 1 year. So in fact, there were indeed 0 studies available to address effectiveness. And the authors wrote they focused on outcomes reported after at least a year of opioid therapy, with the exception of outcomes related to overdose and injuries like fractures, falls, motor vehicle accidents. Studies on treatment of acute exacerbations of chronic pain, studies on how to initiate and titer doses, and studies on discontinuation of opioid therapy, for which in that whole group, they included studies of any duration. So that allowed, the presence of the 2014 AHRQ report allowed the CDC to say in its guideline that no study of opioid therapy versus placebo or no opioid therapy evaluated long-term outcomes related to pain, function, or quality of life. So that was true, but the methodology had shifted. So I'm going to show you some data that we have accepted for publication, but it's not yet published. What we asked was, if you look at the different drugs that could be recommended for pain, or even non-drug therapies, what do those literatures look like? In other words, how long do the studies run on average? Now, I have to tell you another piece of information, and what was remarkable to me is how few people, no one actually, that I saw publicly quoted, said, well, wait a minute, for a drug to get approved, don't you have to do some clinical trials? Didn't I remember somewhere that you had to test the drug and show that it worked and show that it was safe? And the answer is, of course. There's a whole set of documents that the US FDA and its European counterparts have. Those documents were, they selected a duration of a trial based on considerations of being able to do the trial. In other words, if you imagine that the trial had to be 5 years, no one would ever get anything studied. It's just unwieldy. On the other hand, the situation they were trying to correct about 15 years ago was that you could do a very brief trial, a day or two, in people who had a long-term diagnosis and get that drug approved for treatment in that diagnosis, like cancer pain. And that wasn't right. If you're going to be giving a drug for months or years, you should check it and its effects, whether it's working, for months or years. So there were already guidances, and what the guidances had reached as their conclusion before the opioid epidemic was that 3 months seemed like a pretty fair time to check efficacy if you wanted a chronic pain indication, because most people who will display a side effect will have done so by that time. And then if you want to get the drug approved, you also have to have safety data going out to about a year. See, Bob Lennox has lived through that for 30 years, well acquainted with all this. So this is the reality, that if you want to sponsor a drug and get it approved, you need to do 2 replicate 3-month trials. So having given you that additional background, NSAIDs, these are the things like aspirin, ibuprofen, whatever. What's the literature on NSAIDs for chronic non-cancer pain? Well, we found 10 papers that ran from 1 to 7 days, 55 that ran to a month, 27 that ran to several months. And if you think about 3 months roughly as being 90 days, it would actually be 84 according to our 28-day per month. You start to see the fall off. So basically what this says is sponsors are doing studies in order to get the drugs approved according to what they're required to do. Very few studies tail out. Anticonvulsants are often used for pain. Kind of a similar picture. More of these anticonvulsants have been approved recently, and so there's a cluster going closer to the 100-day mark, but they still kind of have that hump and go off. Antidepressants, early hump, falling off, nothing made it to a year. There, only one got close to a year. That was the early one. Only one got close to a year. Behavioral therapies. Interestingly, it's almost the same thing. That hump is early on, falls off. There were many studies where you just couldn't actually tell how long was the duration of the active intervention. For opioids, if you look at the agents that were excluded from the AHRQ report because of inadequate duration, actually they ran off, their tail off was somewhat greater than the other agents. If you look at the Cochrane collaboration review, it was even more so, that there was a falling off. So the point I was making is that the people who conducted the review certainly knew what the literature looked like because they had done this twice before. And by raising the duration of the trial's threshold to be included, knew that the result would be 0 trials would be included. So what are these recommendations? What do they boil down to? In fact, as I've said, the CDC did conduct and published a comparison of different guidelines, and the majority of the specific 12 recommendations in the guideline are actually consensus, common sense, and laudable. So I'm going to whip through these, the ones that are consensus, common sense. Non-pharmacologic and non-opioid therapy are preferred for chronic pain. I think people would agree with that, except that NSAIDs, the first group that I showed you, are widely considered to cause between 15 and 20,000 premature deaths per year. So the risk-benefit statement was skewed or distorted. And this recommendation, clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh risks. Actually, that harkens back to the first of the Portnoy and Foley papers I talked to you about in 1986. If they are used, they should be combined with non-pharmacologic therapy and non-opioid therapy. Establish treatment goals, including realistic goals for pain and function. Well, let me continue this. Clinicians should continue opioid therapy only if there's clinically meaningful improvement. Clinicians should discuss with patients before starting and during opioid therapy risks and benefits of opioid therapy and provider responsibilities. This gets back to the opioid agreement idea. When starting opioid therapy, clinicians should prescribe immediate release opioids instead of extended release long-acting opioids. I think most clinicians would agree that's reasonable because if you have no exposure to opioids, that is to say, if you're opioid naive, your risk of having an overdosage is higher if you're given an around-the-clock delivery of opioids. I highlighted this, though, because although it sounds logical that clinicians should prescribe the lowest effective dosage, this is proven controversial because in the setting, let's say, of a patient being discharged from a hospital, you really don't know the lowest effective dosage. And I would draw an analogy with going out and buying a car. No car that I know of measures the strength of your leg and the strength of your grip to make the car. They build something that will accommodate many people and can be adjusted. So the idea of choosing the lowest effective dose for the least necessary time is logical, but it's not always realistic because you don't know at the time of the prescription how the patient's going to respond. But nonetheless, people would agree with this concept. The question is implementing it. Clinicians should use caution when prescribing opioids at any dosage, should reassess benefits and risks, and there was a cutoff of 50 morphine milligrams equivalent per day, should avoid increasing dosage to greater than 90, and carefully justify a decision to titrate above that level. People have pointed out flaws in this. One flaw is that not every patient responds to every opioid in the same way. Although there are tables that allow a physician or nurse or pharmacist to convert, let's say, a dose of hydromorphone to an equivalent dose of morphine, those tables are based on populations. There are wide variations in every aspect of opioid metabolism and also action. People have different genes that appear to dictate what their response is to a particular opioid. They differ in those genes. Genders differ in those genes. And in the metabolism of opioids, there are also cytochrome P450 individual variants that can make one dose inadequate for a patient and in another patient would be fatal. The example of codeine, for instance, in pediatrics has led to fatalities because it was unrecognized that a certain child may be an ultra-rapid metabolizer of codeine, give a big burst of the active byproduct of codeine, whereas another one may be a slow metabolizer. So we are in an era, well, I'll get to that later, we're in an era where people talk about precision medicine, but even in an area where individual variability is known to be important, there's no allowance, whether you're treating a 90-year-old slight little old lady or an NFL linebacker. This was the point. Long-term opioid use often begins with the treatment of acute pain. When opioids are used for acute pain, clinicians should provide the lowest effective dose of an immediate release opioid and prescribe no greater quantity than needed. How long is this needed? They say 3 days or less. In Massachusetts, the initial draft of the bill governing opioids said that no acute pain prescription could be for longer than 3 days. And people said, well, wait, remember last winter when people were driving around trying to find a pharmacy? It doesn't make sense. That the bill as enacted became 7 days. But again, the data basis for this was not strong. Things that are less controversial, well, you need to evaluate benefits and risks as you're treating someone. When the benefits do not outweigh the harms, you should use other therapies and taper and discontinue. Before starting, clinicians should evaluate risk factors, incorporate into the management plan strategies to mitigate risk, meaning diversion, abuse. Consider offering naloxone. And if there are higher opioid doses, that 50 milligram morphine equivalent mark was chosen again, or there was a concurrent benzodiazepine. Almost done with this. Evaluate the patient's history of controlled drug substance prescriptions and use the state prescription drug monitoring program. That's the law. When prescribing for chronic pain, use urine drug testing before starting and consider urine drug testing at least annually. That's become the standard of care. Avoid pain medication and benzodiazepines because this is a very high-risk combination in terms of suppressing ventilation. And use evidence-based treatment, typically medication-assisted treatment with buprenorphine or methadone, in combination with behavioral therapies for patients with opioid use disorder. So those are the recommendations that everyone's talking about. Most of them are standard of practice. Most of them are concordant with what other professional organizations have stated, and even the original case series that started this all. But at the current time, I would say that the situation is not a stable situation in the long term, because we've spent a decade or two focusing on patient-centered care and learning what's important to patients. Pain is important to patients, particularly if they have a condition that led them to be hospitalized, and that includes labor and delivery. So we have raised the bar of expectations very high, and what we're seeing is an approach of turning back the master spigot, if it were, to just suppress or reduce opioids for everybody. And I can tell you that the people who are in the pain community are often the recipients of emails that are very heartrending, where patients will say, I was a legitimate citizen, I had this, I had that, I had an illness, I had a crash, we tried other things, I've been on a low dose of opioids, they make me function, now I'm to be tapered off. What do I do? A lot of people are out there like that. So this collision between evidence-based medicine in terms of group means and thresholds that are not adjusted for individuals and the call for precision medicine are colliding right now. So what does pain look like to patients anyway? I just want to share with you a couple of things. We have this whole mailing list at Tufts because we've had the program on pain research, education, and policy, and we have affiliations with patient groups. And when Pope Francis visited the U.S. last fall, CNN did something where they just opened up their lines and said, send in 3 words to you describe the Pope. So that seemed kind of interesting, and since it was last fall and September's Pain Awareness Month, we tried that on our mailing list. What 3 words, and this is the word cloud, to people with pain or those who treat others with pain: suffering, agonizing, shame, disconnecting, or disconcerting, disarming. These were major. Pain was in there somewhere. Let me just see where this was. It was mentioned, maybe healing, multidimensional, but to people with pain, my experience as a pain doctor has been not that many are that fixated on medications unless they have a substance use disorder. People want to have their suffering reduced and be less lonely. So I'll leave you with another quote. This is from George Bernard Shaw in the preface to his Doctor's Dilemma. Very interesting play, again, topic for another day. But Shaw pointed out there's no harder scientific fact in the world than the fact that belief can be produced in practically unlimited quantity and intensity, without observation or reasoning, and even in defiance of both, by the simple desire to believe, founded in a strong interest in believing. So I thank you for your attention. You can tell I've tried to be fair and balanced, and I've emphasized no one is defending or extolling the opioid epidemic, and much of the CDC guidelines, in my personal view, are totally appropriate and consistent with practice. I think that they tried to push the envelope, and in pushing the envelope, misused evidence-based medicine to give the appearance that certain numbers were derived from the literature when there was no such derivation. So I hope I've stirred up the pot enough that we're going to have a lively discussion, and I'll stop the talk right here.
Thank you. Would our panelists like to come back to their seats, and we can have a little time for discussion here? Fascinating. Collision course. That's a headline. I'm interested, Congresswoman Pingree, you started off talking about the pendulum swinging back and forth a bit, and how in our attempts to perhaps solve the problem of addiction, we're not so much looking at the chronic pain issue. In hearing the needs and the studies, and certainly looking now at what the CDC is recommending, and the argument over whether that's valid or not, whether doctors should make that decision with their patients or the CDC should make the decision, where do you think government now falls in terms of what you've heard?
Well, as you all all know, Maine is about to implement some guidelines too, which are even stricter, I think, than the CDC. And of course, we're sort of bracing ourselves in our office for people who will be contacting us to talk about how this challenges them. So we're very aware that these guidelines are about to have an impact. And I was really grateful to both the presentations, but particularly your ability to put it all in a little bit of perspective. This isn't my field. I don't want to pretend I have a lot of experience, but some of it reminded me of what happened with sentencing guidelines. You know, we had a crime epidemic in our country, not that that's over, but we had a lot of crime. We had a huge concern on drug use in general, and then we had a war on drugs, then we had sentencing guidelines, and we had 3 strikes and you're out. We had all these things that kind of took away, in a sense, the judgment of judges. You know, we decided to say this is what the courts will do because we don't necessarily trust the professionals we put into those positions. And to me, you know, while there are definitely 2 sides of this, and now we're faced with, as policymakers and politicians, this huge concern on the part of the public, a different level of awareness of opiate problems and opiate addictions, huge impacts on communities. And I would dare to say that part of the challenge too is that it's spread to more demographics. So we're far more aware of it because we're now seeing it in communities we didn't expect to see it. So then there's pressure on politicians. And I would say that rather than address the root causes at times, we go after what seems like the simplest thing to do. We'll just tell the doctors what to do. We'll tell prescribers what to do. We'll tell the courts what to do. So I find this somewhat troubling because I do think we've swung too far, and we do it in a sense because it's easier to start making guidelines or regulations than to say what are the underlying causes, some of which were discussed today. And some of it have to do with, does everybody have adequate treatment and access to care? Is everybody being well served? Are there other chronic things in our healthcare system that get people into positions of pain that we could have prevented earlier on by better prevention and wellness? And anyway, I don't have to tell this room full of people, you know, where we've gone wrong, but I think a lot of times it happens because we don't want to make the investment where it needs to be made. And, you know, we see that with our recent passage of legislation that really touts a lot of very good things, but actually doesn't fund any of them. So, welcome to Congress.
Right. Dr. Porter, I'm just interested in where you think we need to go next, too. You've done this remarkable study. Is it too late almost, as we've discussed, these CDC guidelines are coming out? Are we making assumptions about pain that perhaps prematurely prior to this comprehensive study that came out?
Well, I think things had to happen. You know, clearly we need more evidence base to refine some of the guidelines, the initiatives that are coming out of the government as we move along and update them in the future. So, on the other side of that is no, I don't think it's too late. I think there's so many things that need to be done as far as changing pain care. They're not going to happen overnight. The National Pain Strategy is calling for a series of discrete steps that will lead to a certain point in 5 years towards the ideal state of pain care, but we are not going to be there at that point. These are huge changes when we're looking on a nationwide level that involve payers, that improve, that call for evidence base to really sort of be able to put out the best initiatives in the best ways immediately, but we're not ready for that. The research will inform the future changes, but I think some changes had to be put in place now. I think everybody recognized that there was a need for prescribing guidelines, that there's a need for better education for prescribing, there's a need for better education for pain management, but the question is, you know, how long can you wait to make the perfect set before something goes through? And I think the hope is that these guidelines are guidelines and not strict policies. And the big concerns that we're hearing in that some instances, some states, some healthcare systems, some academic settings, that they really are not being considered guidelines, they're being more considered policies. And that's been, I mean, we hear that at all the meetings that we go to and from patients, from emails, so that's a big concern. And we need to be able, through research, to make the needed changes as we go along.
And Dr. Carr, as somebody who has seen patients and also done the research, do you think doctors are almost looking in a way for these guidelines as opposed to recommendations? Are they somewhat reticent to in this case, prescribe medications that might be helpful to patients?
I think that that many doctors have looked at the guidelines as a way out of taking care of very difficult and challenging patients. Again, I can't verify each and every email that I get, but there's no reason not to believe people who say, I was stable, I was fine, I didn't misbehave, I was a responsible citizen, and now I'm told that the new law says I can't receive this medicine anymore. So we know patients are not being told the truth. I'll give you an anecdote. I saw a patient who was perfectly well managed and employed in a pretty physically active capacity. He was a carpet installer, but he worked all the time, and he had Hodgkin's lymphoma. He was irradiated in a mantle format. He had a staging biopsy, had chemotherapy, and he recovered. But his treatment left him with chronic pain that, for him, a good mixture was a low-dose short-acting opioid 3 times a day and a very low-dose benzodiazepine. This was a young guy in his 30s. So I'm in the clinic one afternoon, it was on a Thursday, and I get a call from a pharmacy saying that they're not comfortable to refill his prescription. And I said, well, what do you mean? I mean, I can't tell you his whole history, it's a HIPAA thing, you know. They said, well, they're just not comfortable. I said, well, do you have a supervisor? You know, because he said, well, if you write a letter, if you make, I said, well, if I dictate the letter today, I'm lucky to see it tomorrow afternoon. It's probably going to be over the weekend that it gets typed, and I won't be able to get back to you on Monday. So we negotiated that he would get a 3-day emergency supply. And then I dictated the letter. So then he handed the phone back to the patient, and bear in mind, this is the topography of a typical pharmacy. The pharmacist's up here, there's shoppers, there's rows. So the patient said, you know, the thing that really bothered me is that this was the same pharmacist who dispensed my chemo to me. The same guy, true story. So there's so much more to say about all this. On the hopeful side, the research that Dr. Porter was describing is identifying targets that they have nothing to do with opioids or morphine receptors. Think about local anesthetic for, you know, dental extraction, things that are just a totally different approach. There's some very promising ones, and some of these clues were evident in the posters today. So there's a lot of promise that is out there in terms of avoiding the problem entirely. For decades, actually, in the anesthesia world, a goal has been to reduce opioid consumption postoperatively because it slows the bowel and interferes with ventilation, and that's always been a goal, and there's little quarrel about that. So I didn't want to sound totally negative. I hope there's some positive coming through, and I think, as Dr. Porter and Congresswoman Pingree said, if nothing else, this is putting pain back on the spotlight, and maybe one of the nice effects will be that people will take this as a series of integrated goals that Dr. Porter and her consultants have worked on for years and tried to get these right, rather than just, let's say, a circuit breaker that just goes off and trips and that's it, no one has any electricity anywhere for the whole town.
It still seems to me that it's a bit challenging for people to understand that just the concept of chronic pain. Most people think pain goes away, and in your slide that showed low back pain being the #1 reason for disability and people not being able to work and those kinds of things, that not that surprising. Everybody's had some form of back pain at some point or another, but it doesn't always dissipate for people. How do you think it's best to educate people that chronic pain itself can be a disease, if you believe that, or a disorder itself, or a health issue itself?
Well, I'm going to defer to, because Dr. Porter added on that separate arm of dissemination and publication.
Yeah.
Right. So the public awareness group was very concerned that there is not a good understanding of chronic pain across the nation. And they actually, I mentioned very briefly that there was a call for a public awareness campaign that would address the stigma associated with chronic pain, better communication with physicians. But they listed very discrete learning objectives that should go out in that campaign. And it really was to better define chronic pain potentially as a disease. So chronic pain can obviously be a symptom of other chronic conditions or injury, but it can also become a disease in of itself when the nervous system has become hypervigilant, if you will. And I think there's a very low understanding on the public level that that is actually the case. And so there is, you know, and probably as a person with pain, you've dealt with this, there's this challenge of convincing people, including your providers in some cases, that you really do have a problem with pain, and it's really disabling because they can't really pinpoint the injury has gone away, the condition has cleared up, so why do you still have pain? And I think this is a huge piece that the public has to better understand. Crucial.
Yeah.
But
And-
again, as
go
a
ahead.
note of hope, this has been done for conditions like depression, for conditions like post-traumatic stress disorder.
Addiction.
And addiction, where, you know, there may have been some traumatic event and you can't see the results of that effect now, but you still believe that the person can have a changed awareness and vigilance system and have an impaired quality of life. So this has been done. It just requires education.
I would guess too, again, not being an expert in this, but, you know, we have a sort of uniquely American attitude that you can fix everything. You know, we don't believe in chronic poverty either. We don't believe in, you know, chronic challenges that people face in a whole variety of ways because we think that everything can be fixed by modern medicine, or you pull yourself up by the bootstraps, or there's just this thing that everybody should be better at everything. And I do think that without a lot of public awareness around this, we don't treat it like a challenge, as you said, as we've learned to treat even depression with a different kind of stigma. And I'm sure that leads to all kinds of complications that make it more and more difficult to self-manage your pain, or to, you know, to live with a little bit of pain, as you were talking about. Because if you have an employer who doesn't believe in chronic pain, and there you are, but in your own pain management say, well, I need to take this little break every once in a while, or whatever you do to better manage your own situation, and an employer says, sorry, that's not even vaguely within our rules or opportunities because we don't recognize, it's just, why don't you take more Advil? Why don't you go see your doctor? Why don't you get it fixed? That's just how we look at things.
Or just suck it up.
Yeah, exactly.
Yes.
Professor
Sure.
Levine.
So are opioids being held to a higher bar in terms of how we evaluate their potential threat promise, how we restrict their use relative to the negative impact that other drugs have, both in terms of their toxicity, including lethality, as well as their addiction potential, such as the benzodiazepines or nicotine?
Swipe one of these for audience, if I may. Share that. Thank you.
Did you want to take that, Dr. Carr? He didn't mean to take your microphone. You can use that one in the middle there.
Not picking on you in general, right?
Proof that there's a conspiracy. I would say, the short answer is yes. I don't think it's as simple as a higher standard. It's kind of like an inverse or whatever, contrapositive. In other words, the statement was made that the evidence for the opioids was inadequate. But if you look at the duration of trials of anything, it's pretty much the same. It looks like it's more a function of doing a trial of chronic pain than it is of what you're trialing in chronic pain. So it amounts to saying that opioids are being held to a higher standard as far as duration is concerned. I'm sure there's a lot of controversy and argument you can make, because as you know, different clinical trials have different quality. They have different statistical strength. There's a lot of reasons why duration alone would not be the measure. But if the entire literature were excluded because of duration alone, and therefore people routed to other agents like NSAIDs, that is not going to stand the test of time.
Sure, go ahead.
I want to thank the panel for what I think is an excellent discussion at this point from the various perspectives. I'd particularly like to address Dr. Carr's point in regard to what appears to be an unfairness, as well as John's point, in regard to the perspective for the way they looked at evidence-based approach to opioid treatment. And the fact of the matter is that what happens when public health becomes a major issue and policy and regulatory agencies come in and medicine and science take a back seat to that, then you lose a perspective. A good example of that we've been discussing at NINDA for a long time and has happened in terms of, it's happened with marijuana. And basically the public has taken the position, has driven it, and the science and medicine are catching up. In the case of opioids, you've got evidence of what appears to be, and that's a lovely slide you've got, of an epidemic that's taken place. And so the CDC takes hold of it and does what it does well and makes a policy. And you're absolutely right. I mean, in terms of the pharmaceutical industry, for instance, in developing a drug, to arbitrarily pick a year to evidence chronic effects, even hyperalgesia, is not evidence-based. When we look at programs, for instance, for multiple sclerosis, we had to make decisions about what time frame we were going to look at. And thankfully, and this is a particularly difficult disorder because you got exacerbations and remissions, and you got to look at events over time. And the fact of the matter is we had help because we were able to use MR and weighted 1 and 2, and we were able to look at new lesions versus existing lesions in the brain. And so we were able to set a period of 3 months, which is reasonable. So I think Congressman Pingree said it well. I mean, she alluded to the fact that there are swings. And that's what we're seeing. We're seeing a wild oscillation. Suddenly, we're facing an epidemic. The public needs to take action. Our governor feels he knows where that action's got to be, as it will be in other states. And these are done. And these are more than guidelines. These are codified. All right? And that's what happens. It becomes, we lose the science, we lose the medicine, we start to deal with belief, and we act. And I think you've shown a very nice example of where we are at this point, and I think we have to move beyond it, as Linda was saying.
Okay, over here.
Thanks for some great insight. I want to get back to a little bit of policy, and I think some of the frustrations we have. I'm the dean of the College of Pharmacy, and I think from a pharmacist perspective and other healthcare professionals, one of the challenges we have here in Maine is our PMP process. Part of this is how easy it is to use the process, and our prescription monitoring plan in Maine is very cumbersome, and you really can't get that good data on how effective it is compared to other states. It just isn't that effective. And so I think it does limit prescribers and pharmacists to want to do this because they don't want to put at risk, because the data they have to see if this is a legitimate prescription, it's very hard. It's a list, it's a list from various pharmacies and various elements compared to other states where you can actually see how much that patient has gotten over the last few days. So I think part of the challenge that we might have is that we've got to have the technology and the tools such that our practitioners, our healthcare practitioners, can better monitor the use of these opiates without having systems that are very cumbersome. And in Maine, our PMP is a very cumbersome process. So I know it's affecting pharmacists and clinicians and everybody who wants to be able to do that, because you put yourself at risk if you don't, add that information. So I think policy and tools are going to be critical in trying to manage the system at a state level or even at a national level. How do we better control these? So I really appreciate the linkage between the science, the policy, You know, and most importantly, it's about taking care of patients. And I think that's the bottom line is, and an integrated healthcare approach is going to be necessary, but we've got to have the tools, not only across the country, but in individual states. And I hope as we're looking at this process that we're going to think about getting the healthcare practitioners these tools so they can better help to manage patients. If we've got things like this, we should be able to get to a database where we can help to manage patients.
Our panel agree, or any comments on that? No, just good point. Okay.
I think she makes a good point.
Valid point.
Another issue that comes up with that is sharing that information from state to state is proven to be very difficult. It's collected differently everywhere.
Sharing it across different healthcare systems is challenging too.
Mm-hmm. Any other questions? Anybody? Sure.
I guess I should probably say something since I kind of meet the criteria that you were speaking of, the guy that did carpets. I've been taking prescription hydrocodone for 10 years, and I've had to whittle myself down to, I take 4 a day, that's it. And you can believe me today, I'd love to take 2 more, but I can't. I limit myself. But I also live in fear that every month when I go to get my new prescription, they're going to say, well, you're not going to get it, which means I'm going to have a really rough month. So I'm just glad that at least something like this is happening. Thank you very much.
Sure, right up there in the corner.
I'm wondering if you're aware of the Choose PT campaign, and if so, what you think of it as an option for pain relief without opioids?
I'm not aware of that particular campaign, but I bet you I support it. One of the physical therapy has been an enormous help for many different pain conditions. It's clearly part of the multidisciplinary care package that some private insurers are now at least paying for a moderate number of sessions and recognize as being really important. So that clearly needs to be rolled into an integrated package of pain care for many, many people. And so I'd like to learn more about it.
Yeah. Yeah, it is fascinating in terms of coverage. When I was first diagnosed, I was allowed physical therapy for maybe 6 weeks, and I thought, great, it'll be gone in 6 weeks, 18 years later. But it was very helpful, and it is sad that insurance companies are not looking at these alternative treatments, some of which you can do on your own, and some, such as acupuncture and otherwise, really are helpful. So that would be a great step. Sure.
I think it's done on purpose.
Getting your workout.
I hope when they do these criteria and stuff that they look at the patient and make the plan for that patient, because every patient is different. Some can do physical therapy and some can't. So, and some can't take opioids and some can too. So I'm just hoping that through all this research and everything that they still go back to the patient and look at that patient and look at the history of that patient and say, okay, we have to make a plan for that one. This one over here is different. Everybody is different, every patient.
Yeah, so the ideal state of pain care includes the patient as part of the team that makes the decision. So there's a communication issue in there, but it's really geared towards team-based care where the patient is the center. Understanding their needs, better pain assessments, so you can actually start to determine what their risk factors are or what they might benefit from. Again, this goes back to payer incentives, where the team, the group discussions, the group planning are not covered, and I don't even think there's a code to charge for that in the insurance policies. So that's clearly part of what we hope we'll be moving towards, but again, it's a long, slow process that needs a lot of changes to be implemented to get there. So,
Yeah.
important concepts, very important.
Yeah.
Yeah, hi. I've really enjoyed the discussion so far. I have 2 thoughts, and one is in a couple of ways, this idea of a pendulum between treating pain and taking pain seriously and then worrying about addiction have come up, and how the pendulum swings back and forth, or variations in policy. But of course, we can't have that. Both are true. We need to adequately treat pain, and we can't have people being addicted. And I'm wondering what we can do, both from a scientific and policy front, to kind of move both of those initiatives forward in parallel and stop seeing them as conflicting. And then the second thing I was thinking as I was listening to you guys talk is, it seems to me that opiates might be unique in kind of the moral kind of risk or the moral thing we assign to them, right? We don't kind of judge people who take statins, or we don't judge people who take NSAIDs, but we do kind of have this stigma that goes along with taking opiates, and we see them as somehow dangerous in a way that we don't with a lot of other drugs. And I'm wondering if that gets in a way of kind of rationally legislating and rationally prescribing them also, and if you guys have thoughts about that.
I think it's a really good point, and I was just thinking about that because I forget which doctor said, do we hold these medications to a higher standard? And I think we do. I mean, we used to hold antidepressants to a different standard. It was very stigmatized, and now we know a lot of the population takes them, and we think it's a good thing that people are basically more stabilized and can lead more healthy, productive lives. So I do think that's true. And I was thinking about, especially Maine has an interesting and long history with prohibition. We've got a kind of stigma about altered states and our recreational use. And clearly we're altering some of that thinking around marijuana. First we decided it could be a medical tool, and now pretty much my guess is we're gonna see every state just go ahead and legalize it, partly because it brings such wonderful tax revenues to states like Colorado, but also people have just started to say, how do you compare alcohol use and marijuana use, and how do you continue to draw this line? Also, it becomes this, it becomes a gateway criminalizing drug. Maybe some people think it's a gateway addiction drug, but a lot of times it's your first step in jail, and then you have a hard time getting out of that chronic practice. But anyway, I'm just saying I kind of agree with you, and I was thinking about that we have a moralistic underpinning in our culture, and I think that some of this is this idea that people have been misusing pain relief substances because they can create an altered state, and so they're just out there having fun. And so why should people be having fun when they said they had a pain, but really that's what it was. That wasn't it. They just wanted to go have a good time, and then they become addicted and then become problems. So I do think we have a lot of confused thinking around it. And all these kinds of conversations and good policy making and bad policy making, hopefully eventually leads us to a point of some kind of balance, some kind of understanding, more respect for chronic pain, all these other things that we now actually have a chance to have a dialogue about. But I would say right now we're still stuck in probably somewhat of a bad place. And I think we're going to do some damage to people's ability to be high functioning or to lead a quality of life that they deserve. And in our modern world of modern medicine, we expect better outcomes than that. And so to suddenly be so restrictive could cause some problems. But I do think it gets us thinking about all these other things, like what else, whether it's physical therapy or just general wellness, because a lot of time pain comes not just from the result of other treatments or an injury, but for a lot of people it was an end result of diabetes or things that we could have done a better job starting with infant care, school lunch programs, and a whole variety of other things that we need to recognize as well. What is it to be healthy and well in our country? So it's a big, big topic, I think.
Let me add, while you're bringing the microphone down, that, just three quick things. The first is that the National Pain Strategy is freely available online and downloadable. And so in answer to your question about how to balance together the moving parts, that was essentially the task of the National Pain Strategy, because there are a number of moving parts, and Linda worked for several years to do this. So that's freely available. Your tax dollars paid for it. You can go online and get that. The second thing is that I do think that historically addiction among all different disorders has had a very special condemnation by society, because it pits the actions of the individual against the benefits of the social group, and it undermines society. So people have always scorned addiction. But let me conclude with a statement that I think it's impossible to understand the phenomenon of chronic pain without understanding the phenomenon of stigma. there was a huge literature on stigma that already had arisen way before the current opioid crisis. And how I would frame this is that we are herd animals, and you can go on YouTube and see other pack animals behave the same way. If there's an injured animal for a little while, the pack will support it and try to nudge it and get it to go on. If it doesn't recover quickly, you can see the packs turn on whatever, wolves, monkeys, whatever you want to see, that they will kick and expel and beat the injured member of that group when it can no longer help the group defend or feed itself. And I think we have exactly the same instincts, both as a population, but also internally, because people with chronic pain themselves will describe being ashamed or depressed, and what that translates to is they're going away from the herd, they're going to crawl up in the cave, and they'll either get better, rejoin the herd when they are functional, or just die. And that's our internal synergy with the group reflexes. So stigma is a very important unmentioned thing in this whole debate. Unfortunately, our current political and social climate is one where almost any topic begins with one person denouncing the other. And that's the starting point, and it deteriorates. Therefore, anyway, I've said my 3 things.
Go ahead.
One really quick follow-up to your question and to Congressman Pingree's comments. You know, there is not good evidence, and the public needs to be more aware of this, that people who use opioids to treat chronic pain are responsible for all the problems associated with opioids. And I think there's a lot of finger pointing, there's a lot of shame associated with that really has no basis for it to exist. There's nothing to show that the diversion comes from the people who get the prescription drugs. There's nothing to show that these people are more admissions to the emergency room, or that these are the people who are more likely to die from overdoses. And again, that's a public awareness issue. And another point to your question, one of the things that we have not been able to do well for either getting good signatures, biomarkers, indicators of chronic pain, or risk factors to develop chronic pain, or to be able to identify people who are at risk genetically, physiologically, psychologically for addiction. And those are things that are really holding us back to try and keep that pendulum from swinging back and forth. We need that knowledge.
One is the point, back to the question I did want to ask, which actually does relate partly to what Linda was saying, but in Middle English, the word pain means punishment. And it comes from a religious view that your pain was given to you because of something you had done. So as an alternative to the herd hypothesis. But go ahead.
I can't keep quiet on this kind of put together talk on stigma. The origin is presumed, it's called Proto-Indo-European, and the word is poena. It entered the Greek language as the word pena, which is exactly what you're saying. It's the same root as penalty, penitence, penitentiary. The Greeks were more sophisticated than we were, however, in their daily language about pain, because they also introduced, as you know, terms like dynia, algia, and those different terms had different meaning. In other words, algia was used when tacked on to the name of a body part to mean a pain that stayed, like in your knee or in your headache. Dynia, I believe, was used as a pain that captured your soul, or cooled or chilled your soul. And they discerned these very well, but you're absolutely right. So what we've done, we picked the one word out of 4 that was a much more broad spectrum, comprehensive vocabulary. We chose the transactional one, and where you can see this perfectly in an archaic text that became the Book of Job. If you look at the Book of Job, it's an incredible story about stigma, because the assumption was that God, he must have done something wrong for him to be afflicted with the boils and pain. Yeah. That's what the whole Book of Job is about. So,
but
that was pretty good.
So Linda's comment, I think, began to address my question, or the issue that I wanted to raise for discussion, which is that a very major part of this, quote, epidemic and the consequences that have come from it actually have come both from diversion as opposed to its use in pain, and also with the appearance of a large amounts of synthetic opioids, especially fentanyl, coming from Mexico and South America. And as a consequence, which is probably one of the most lethal, as you know, of all the narcotics. And so as a consequence, we're punishing patients, right, not for the addiction or the consequences of the opioids that they've been given, but actually for a group of individuals who do not have pain, right, who also do not know how to use it and are using illicit forms and are dying in large numbers because, in fact, it's in the wrong hands, not in the hands of a patient with pain.
So I know we're running late, but I've got to add one thing. It's not fully scientific, but my son said, yeah, I heard you talk about this. Why don't you go Google on the term rat park? How many people have heard of rat park? Few. So I did this. If you Google on the word rat park, the second or third thing down will be a comic strip description of some work by physiological psychologists in Canada in the 70s and 80s who asked a very simple question. They said, well, we now evaluate the addictive potential of drugs by taking a single rat, putting it in a glass and steel cage, putting some catheter in its brain or bloodstream, and doing something aversive, like an electric shock or a bittering agent, and having it overcome the aversion by being given the drug. And if they will sip water that's bitter and they normally would reject, but they'll take it because it has the drug. Or if they'll tolerate an electric shock, but they'll still push the little lever because it gives them the drug, we deem that drug to be addictive. So what if the whole basis of testing in that way is distorted? Because rats are normally social and gregarious. They continually probe and roam around the territory. They explore. They go into crevices. What if we took a rat and gave it 10 times the amount of space, and we put sand and shavings on the bottom, not just glass and steel, and we had a picture of a little forest around, and we had little tubes that it could crawl into and explore, and most importantly, if we allowed it to have other rats and mate, have litters there. So they did that. And again, I don't want to oversimplify the thing, but what do you think happened? They didn't want addiction. And look, just let's take a step back. We're sitting here, this is a really select, wonderful group of people. I have no doubt that given your intellectual and organizational capacity, if you wanted to get heroin or OxyContin, you could certainly do that within 24 hours. So how come you're not doing that? Well, you look at me like, what a crazy question. It is a crazy question, because why on earth would you want to do that?
The sad truth is we actually lose a lot of anesthesiologists.
Okay, but my point is that the people in this room are most capable people. They're just not interested. I mean, if someone came to me and said, hey, Dan, here's an 80 milligram tablet of OxyContin. I'm giving it to you, so go ahead and take it, right? I'd say, of course not. I'm not going to do that. And everyone in this room, I think, would have the same reaction. So what seems to be missing is, and I'm going to get kind of hype here, but it's a little bit of a purposeful sense of daily life, of doing the tasks that we're evolved to do. Take those away. You take social creatures and isolate them. You give them nothing to explore, no possibility to escape. So you're actually, in reality, doing the drug screening tests in a tortured animal. And
so
what animal?
You're describing that part of human culture, right, which actually, in which drug addiction was the greatest up until this current epidemic. And there was an epidemic within the ghettos of drug abuse going back decades and decades, and this large whole thing blew up in the public eye only when it began to impact, the white community.
So there's no question these are addictive agents. They're controlled substances. The DEA screens. There's no question about that. On the other hand, it's not just a question of the substances. Having said that, one of the other things that's being done on a very wide scale is developing abuse deterrent formulations, so that the most common means of drug abuse, like crushing, dissolving in alcohol, those are generally not going to yield the same high or result. And that's an area that is under active exploration, because to some degree the formulation science, I think, is a little easier than finding a whole new molecule. So you can take what you know works and do the formulation. But the fact is, it's a complex issue. And I also think that all 50 states have witnessed a decrease in prescribing of opioids in the last 2 or 3 years. So it's going to be impossible to figure out which factor made that happen. But it may also be a factor that's not even measured. It may be a factor like the stigmatization of a prescriber who prescribes an opioid, who feels uneasy now because they're being watched and condemned socially.
All right, well, thank you all so much. I just would wrap up by saying how much I appreciate this conversation today. As somebody with fibromyalgia, which has a big umbrella, every now and then a new symptom will arise, and you're not sure, is this related, is it not? And I went to a doctor once and said, I'm not sure what to think. And I said, but what if it is just another thing to live with? And he said, well, then I can't help you. And that's a terrible sinking feeling, because there are plenty of ways that we all can help chronic pain patients. There are plenty of avenues, different therapies, modalities, psychological things you can do. Never underestimate the power of doing something you love. I love to live in the moment, but when you're in pain, you want something to take you out of that moment. So sing or dance or write a story, or, as in this case today, come talk about something real important that means something to you personally. So thank you all for being here today, and thank you for caring.
So I'll end with just a special thank you to our panelists, to our moderator, to the audience, and a real big shout out to all the staff and students, and to the organizers, but the volunteers that made all this happen. We've got a great reception out here. We've got some more posters, so please come out and mingle.